All right. Well, good morning, everyone. I'm Larry Boris, Executive Director of the National Association of Worksite Health Centers. I want to welcome you to our first Monday roundtable, the first Monday in February. We're pleased to have a discussion today about unlocking the value of clinical patient data for on-site clinics, a topic that a lot of people have raised with us in the past about how to get information from their EMR systems, what kind of information to get, where do they find it, how do they use it, how do they bring it together, and how can it help them give better overall quality and improve the care that they deliver. Next slide, please. So for those, again, who are interested or just visiting us today, the National Association of Worksite Health Centers is the nation's only nonprofit group supporting both the purchaser and the supplier side on on-site, near-site, mobile, and virtual health centers. We assist employers in understanding this type of health benefit and developing and expanding the capabilities of their centers into primary care operations. We also help the health providers and the third-party vendors as well in learning about purchaser needs and how to understand populations and how to better serve as a benefit plan for the employer to deliver services in what we call employer managed healthcare. NAWC offers a variety of educational programs, roundtables like the one today, benchmarking surveys, purchasing support, and other information. We have the nation's largest clearinghouse of information on worksite centers. And so please visit our website at nawhc.org or our LinkedIn group to learn more about what's going on. Next slide, please. So here's some of the upcoming programs. Each month we have two sessions, and we have a roundtable the first Monday, and then usually one the second or third week of the month. So following today's program, we've got the webinar on February 20th on direct contracting. Then in March and April, you can see the others. Our annual meeting is on February 15th and 16th in Dallas. I hope you all can participate in that. Next slide. So this is our roundtable, and it's a little different than our webinars. What we like to do is have everybody participate in this whenever we can. So there'll be a presentation content about the topic for about 30 minutes or so. And then we're going to go around the table and ask everyone for their own questions, comments, shared experience, etc. And then this is going to be recorded. So if you have to jump off early or you're not able to make it or you want to share it with someone else, there will be links available for NOWIC members and on our website as well. So this time what I'd like to do is just kind of see who's joining us today. So please just give me your name when I call it, your title and organization, if you would, please. So Ben, would you introduce yourself, please? Ben Newton?
Yeah, Ben Newton. I'm a practice CEO at Milliman.
Thank you very much. Dr. Sarah Pastor?
Hi, Sarah Pastor. I'm a family physician, head of primary care advancement at Elation Health, which is a primary care focused EMR company, and also actively practicing primary care physician at People Centered Health in San Antonio, Texas.
Thank you. Dr. Rob Goldsmith. Rob?
Good morning, and I'm sorry for not having my photo up there. I'm munching lunch as I listen in. Rob Goldsmith. I'm the president of NBS Healthcare Group. We provide corporate medicine consulting services.
Thank you. Allison Zucker. Is it Allison? Introduce yourself, please.
Hi, everybody. I'm Allison Zerker. I am the Benefits and Occupational Health Manager for the city of Davenport, Iowa.
Great, thank you. Dr. Ben Aiken. Ben, introduce yourself, please.
Hey everybody, I'm Ben Aiken. I'm a family physician with a direct primary care practice called Lantern in Asheville, North Carolina. I also serve as the head of direct primary care for Decent, which is building level and self-funded plans around direct primary care for small to mid-sized businesses.
Thank you. Gary Wald, introduce yourself, please.
I'm Gary Wald. I'm practice chief operating officer at Milliman.
Great, thank you. Glenn Benjamin. Glenn?
Hey, good morning, everybody. It's Glenn Belemjan. I'm with Merck. I'm a corporate account executive in the employer division for Merck.
Thank you. Kate Friedman. Kate, introduce yourself, please. Friedheim, sorry.
Yeah, Kate Friedheim. I am the product marketing manager at Plurigen Health, at Milliman Plurigen Health.
Great. And Neil McComas. Neil?
Hi, Larry. Good morning. Neil McComas. I'm in a sales capacity and business development capacity here at Milliman Plurtum.
Okay, Patricia Docker. Patricia?
Hey, it's Patricia Daker. I'm also with a Milliman Plurtum team, and I head up clinical operations.
Great, thank you. I think that's everyone. So at this point, let's go to the next slide. And I'll turn it over to Ben Newton for the presentation. Thank you, Ben.
And thank you, Larry. And I will give you props for diving in and pronouncing everyone's name. That's always a that's always an exciting prospect. But nice to see everybody today. So what we're going to start off with is Dr. Sarah Pastor, Dr. Ben Aiken, and myself. We're going to kind of do we're going to do kind of a relaxed, fired chat is what I think about it, kind of a round table talking about the topic for to about the bottom of the hour, and then we want to open it up to questions, comments, ideas from the rest of you. But yeah, I mean, let's just get right into it. So I think even before we start, when we were talking about getting prepared for this, as there is with a lot of terminology in healthcare, that you can use words and those mean different things to different people. So we say clinical data, what do we mean? Well, we fundamentally mean the information that's related to the patient's care journey, particularly things like electronic health records, disease codes, symptoms, clinical details that are being captured about them. And it also now in the modern times that can even include things that you wouldn't normally think about, like device data, and it could be very broad. And Dr. Pastor is going to talk a little bit more about that. But the other piece as we go into this, as we think about clinical data, as is often the case really in any industry, we talk about having the data, but we don't really talk about what we need from the data. So I think kind of as a structure as we're going forward, there's really four things to think about data. And this is something I've seen. I've been in a lot of different, kind of from the big data, parts of enterprise software in the 2000s up until now. And there's really the same four general characteristics you want from data. You want it to be comprehensive. You want it to represent all the things that you care about in this context. You want it to be high quality, because the reality is low quality data means low quality results, right? You want it to be actionable, because you want to be able to do useful things with it. That's what it really means. And you want it to be timely, because you want it to be up to date enough so you can actually again, use it for something useful. Now, as we're getting started here, I always like statistics, and I think it kind of puts things into context so we can think about what's really going on. And I think in particular, when you think about clinical data, there's a sense, if you read the news or listen to that, oh, clinical data has been solved, it's moving around. I think anyone who's actually dealt with it knows that's not really true. And if we look at some really interesting statistics we can see here. One is that, yes, most, and I think 96% is actually a little low now, for how many hospitals and healthcare organizations in the U.S. use electronic health records. Basically, most of them, almost all of them, do it, versus less than 10% only 15 years ago. But the problem is that a lot of what is called electronic records is not really as useful as you might think it is. We're still heavily reliant on faxes moving around. I mean, anyone who's spending any time in a any sort of medical office is seen that. And one of the things that's underneath the surface, and this will kind of come up in some other discussions, is that even when it's, quote, done the right way, it's really being done through very, very old standards. And what that means is that it's really not matching up with modern technology, which again makes it hard to use. And so what that means, and when we get down to the bottom of it, is that one statistic from GE Healthcare, which has always stuck with me, is that they were estimating that 97% of healthcare data is not actually getting used. And what it's doing is it's actually making the job more difficult for clinicians. So I think as we talk about this, that's really a context to help us understand what's truly going on. So we go in here, we want to see Sarah kind of give us the context from her perspective, particularly for primary care. So go ahead, Sarah.
Yeah. So as a primary care physician, you have to think about the role of primary care in the care of a patient. And the truth is that we manage more data and information, more tasks and activities, and more collaborators of care per patient than any other medical discipline. And that means that we have a lot of data and information and conversations to handle and a lot of cognitive burden that's associated with that. This group might not be directly concerned about Medicare beneficiaries, but this slide is a good proxy for your most complex beneficiaries that are involved in the management of worksite centers. And so when we look at those complex patients, we see that each one of those on average has 7 unique physicians or other clinicians involved in their care. And those primary care physicians that are taking care of them have to exchange data with, on average, 229 physicians and other clinicians in 117 different practice settings. So this really sort of puts it in scope of the amount of data that is trafficking in and out of a primary care practice on a regular basis. Next slide, please. And those data pieces are coming from many sources, and potentially we're getting data from hospitals and health systems, from other practices, from labs that we're sending patients to, imaging centers, pharmacies, patient registries, public and private payers, other EHRs, health information exchanges, and even more recently, patient wearables and remote patient monitoring devices. Next slide, please. And so I think it's important to align around what the 3 primary use cases are for all of this data. And obviously, what we're all aiming to do is to achieve the quintuple aim. It used to be the triple aim, and then the quadruple aim, and now it's the quintuple aim. And the heart of that is improving outcomes and lowering total cost of care. And so this all starts at the population level. If we know what our population's risks are, where the money is being spent, and we really understand the data that are attached to that population, then we can tailor our programs, our interventions, and our resources to have the greatest impact to drive better outcomes and lower costs of care. And then the second use case is at the patient level, because we cannot improve the population without doing it one patient at a time. And so we really need to understand the data picture for an individual patient so that we can manage that patient's care. I can't improve the 30-day readmission rate at the population level without knowing individual patients that have recently been discharged from the hospital, for example. And it is so important that that individual patient level data is on a bi-directional exchange, because we don't just want to talk about the data that primary care needs to better manage the patient. We also want to think about the data that needs to go somewhere else for other people. Maybe it's a work site, or maybe it's a subspecialist office, or a physical therapist, or a hospital. But we need to think about, sharing what primary care is doing out with those other collaborators of care. So that bi-directional piece is so essential to success on the population level, one patient at a time. And then finally, we really need to know how we're doing. So this idea of performance management, getting feedback on, did this program that we implemented actually impact outcomes and costs for population? Let's say for our diabetics, or for a population of patients that are at high risk for obstructive sleep apnea. Like, what are we doing, and how is that impacting outcomes and costs? And so, and this may also involve, how we are performing in our contracts with payers or with employers. And so understanding, getting that feedback on how we're performing, and then being able to tweak those programs to improve them is so important, both at the group level, but also at the individual patient level. Next slide, please.
Oh, yes, I think we'll get right into the discussion. Thank you, Jared. I think that's a good way to frame this up. And so what we're going to do now is we just want to just give you guys a chance to hear from Sarah and Ben's experiences as they've been working in this day to day. And so we're going to go through a couple different areas. And when we were prepping for this, I think it was you, Sarah, that used the term signal from noise, which, you know, the expression I've definitely seen in other places, and really, you know, how you're pulling value out of like this massive data. And I mean, it really comes to me as I think about it. When I first got exposed to some of this, my brother, who is part of a clinic, and he runs his own clinic now, and I remember him inviting me to see how things go day to day in his environment, and I remember just being completely floored by the amount of paperwork and just, I mean, first of all, I didn't realize that faxes was still a thing. And then to actually see the amount of stuff that he had to deal with. And I thought he was joking when he would say 95-page PDFs. He wasn't joking. That was on the low end. And he would even one of my favorite stories, he had a really nice man who was a veteran. He was very sick, and he would literally carry a briefcase around with all his medical records. And so you can see that something's not always quite right there. So I thought where we could start is, Sarah, you kind of talked a little bit about this, but from your experience and what you're seeing, both, you know, in your position in Elation and as a practicing physician, what do you think is working and not working in particular that you see day to day?
Well, I think we are now starting to get more data through the HIEs have been very helpful in terms of getting that data exchange. Um, And you know, we're getting better data exchange electronically with labs. Instead of like getting a PDF report, I can get discrete data from a lab, pharmacy exchanges, things like that. So all of these things are starting to work better. But where we are still floundering is that, you know, number one, if I want to get data from another practice or another institution, I typically have to send a fax to request that data along with a, you know, consent from the patient. And then I have to wait for them to respond to that. And then I get, you know, let's say a 95-page document that is a whole bunch of redundant information from an EHR. And I have to sort and sift through all of that to find maybe the 3 nuggets of valuable information. That's very time consuming. And you know, you multiply that by a panel of 1,000, 1,500 patients. It's so difficult. I mean, you just wind up not reviewing that stuff. And so things get missed. So that's one thing. Another thing is that, you know, we still are not getting that timely ADT, what we call ADT data, admissions, discharges, and transfers. So really hard to know which of our patients have recently been discharged from the hospital. And then, you know, when we are dealing with the information that's coming from the HIEs, it's usually a big data dump. And again, I am sifting through a mountain of information on top of the daily avalanche of information that you mentioned, Ben. The daily avalanche of faxes and, you know, results and all this stuff that comes into a primary care practice on a regular basis. That now I've got access to more data through the HIE, hallelujah, but I also don't have any way to identify what in that data dump is important to me and actionable. So I think those are the 3 things that come up for me. Interested to know what Dr. Aiken has to say.
Yeah, I think, I mean, Sarah, I think that you're spot on. So coming from that primary care lens, really there's the volume of data and how do you navigate that, and getting, you know, so if we're starting to chip away at this idea that all of the data that's coming in is now in discrete fields, from a tech perspective, really those fields are built most of the time from big systems for coding and for billing. And so what that looks like at the end of the day in terms of a node that comes into our system is, to Sarah's point, you know, you might think, just to kind of put some perspective around this, if, you know, if we're just trying to get basically some information from a hospitalization on a patient, as an example, in PDF form or even in kind of broken out discrete data field form, this may be 5 to 12 pages worth of data that is formatted, again, for coding and for billing. And so then when that comes into our system, or that comes in PDF form, not only is it voluminous, it's actually kind of formatting wise, like the user experience of that is pretty suboptimal. And so to actually kind of tease through that and get those nuggets, the things that we really want to, you know, are actionable for us, is really an area of opportunity broadly. Another thing I'll speak to is I think that a lot of the effectiveness of data transfer depends on the situation in which you're in. And so if you are, for example, part of a big integrated health system in a region, and everybody within that health system is on one of the big legacy systems, so the same electronic health record, for at least a good majority of the care that happens within that region, you may actually have pretty real time and good access to data. You're not necessarily using the fax machine to reach out to the specialty office to get X. You probably have direct access into the hospital charts. That being said, in those systems, I think connections to the other big systems is still a pain point. So the big legacy EHRs tend to have their specific or preferred HIE, and do those HIEs, talk to each other? That can be a problem. But I think one thing that I want to speak to, and this is just my lived experience, is that for those of us that are not part of one of those bigger integrated health systems, so independent practices, folks that are in worksite health centers that are operating on perhaps a different system that's more built towards that ambulatory or worksite center. How do we then connect into these big systems? And so HIEs is one step in the right direction. And there's some legislative efforts that are really pushing those things along to make them more accessible to those of us that are independent. But kind of this thinking about kind of the buying power of a small independent practice that's servicing a population, our ability to kind of tap into the same level of integrations that a big integrated health system has is really quite disparate. And so that certainly, is an aspect that comes to mind in terms of an opportunity for improvement if we're really trying to kind of standardize across and allow folks that are both independent or part of systems to really have access to the same data so that we can best take care of our patients. There is certainly an opportunity for improvement there. So those were, I think, my initial thoughts on top of Sarah's.
Yeah, thank you, Ben. I think that's some key things that I'd want to emphasize again. I think is something that struck me as working with, physicians and with clinics and different healthcare organizations about this kind of data is really when you say it was built for billing, the data is built for billing, fundamentally it's not built to understand the patient. That's not what it was optimized for. It wasn't optimized to describe the patient. It's optimized to describe things that happen in the clinical setting, maybe, or they got billed. So I think a lot of times that's something I've seen that's a bit of a switch we have to make, is we have to be communicating data in a way that actually helps medical professionals understand their patients and be able to treat them better, right? And with less effort.
Absolutely. Two other kind of related things just came to mind that feel like current pain points and opportunities related to what we're talking about. And it really orients around kind of proactive versus reactive data. So, historically, kind of what happens in that primary care office is, hey, somebody is coming in for some type of an encounter, and that then triggers the clinician to engage and say, I wonder what has happened outside the walls. Have you been anywhere else? Has anything else happened? And then there's this kind of reactive process where we go out and reach out to find information. The other setting in which that happens is somebody signs up to become a part of my practice. So we schedule that initial appointment. I get to know them. I ask where they've been seen before, and then I go out and try to kind of scour the records to find this previous information. And in both of those instances, really, I think if primary care is functioning optimally and serving the patient in the best way, that all happens actually in advance. And it's not necessarily encounter-based. So, hey, somebody engages and has decided that they want to come to us for primary care. Hey, there are processes that are really tech forward and data driven where I can kind of basically bring in, go on and get a picture of all of the things that have happened to this person, let's say within the last 6 to 12 months, and kind of build this framework so that when I'm meeting them for the first time, I'm well ahead in terms of what I can start to work on for them. And hey, perhaps there's some things that I can actually start to work on without actually seeing them anyway. Like it could just be messaging based where I say, hey, listen, I'm seeing that you're due for this. Can I help get this facilitated? And then the other relates to a lot of what Sarah was talking about, which is this admission, discharge, transfer data. So we all know that, right, from an employer perspective, really these high cost things like seeing somebody in the emergency room or being in the hospital and having to go back into the hospital, if there are kind of proactive ways where basically that data is getting pushed out to primary care so they're alerted as immediately as possible and can follow along and then really pick up that baton when somebody leaves the emergency room or leaves the hospital, that really starts to function more optimally than, for the most part, what happens in a little bit more reactive way, which is that patient is discharged, they're handed a piece of paper that says, please schedule, with your primary care provider. An appointment is scheduled. Maybe or maybe not, the patient shares, hey, listen, I'm coming because of a hospital follow-up. They come, they have that appointment, and we still, haven't even thought about actually getting the records, versus an alternative scenario where, hey, listen, an automatic, ping gets fired out from that hospital system, alerts us to the process. We're already aware and maybe proactively reaching out to make sure that that patient schedules. Those are very different scenarios. And really data and how data is transferred between the two is the driving process.
I think you described that really well, Ben, because I think two things from it, I think really pull out of what you said. I think when you talk about, either it's onboarding, if you got a new member to your practice or you're bringing on a new employee from one of your employer contracts, fundamentally building that picture of a patient is much more difficult than, people would normally think. Because I think a lot of times when you think of medical data or medical records, people imagine like a single lab report, or they imagine these very discrete things. But the reality is even someone who has not been terribly sick can have hundreds of documents spread across, many healthcare systems. For someone who is sick, they could be across dozens of systems. And so what you're really trying to do, unfortunately, in today's world is you're having to piece together data from potentially a couple hundred documents. Like in my case, when I pulled my data last, I had, 200-300 documents, and and also because I moved between states, they're spread across multiple states. So I think that makes it very hard, and no one should expect a single clinic or a doctor for sure to be able to do that. Like that just doesn't make sense. And we would hope that the system would actually communicate in that way, but it doesn't. And I think also what you said there about the, with trying to get these discharged information when someone is in the emergency room, that very discrete amount of data, it's kind of on the opposite end. But that's exactly it. You need something to be timely. You need something to be in front of you so you can, because a lot of times you have 20, 48, maybe 72 hours to deal with that patient and help them move along. And I know, like, here in Nashville, where both Ben and I are at, like, I've seen examples where, the doctors would get a 2-line admittance notification and a 2-line discharge. It said basically, Ben was admitted, Ben was discharged. I mean, what are they supposed to do with that? There's really not a lot of information. So I think there's a lot that can be done there, and I think makes the job harder than it needs to be. Now, one thing I know we want to kind of have the bigger discussion, but one thing I definitely wanted to get to before we move on too far is, Ben, you have built a business here in Nashville with, starting multiple clinics and, building out your business, working with employers. And one thing I'd be really interested to hear your kind of view on, like we were talking about specifically kind of in a clinical setting with a, doctor treating a patient, a clinic working with a patient. So when you think you're working with a new employer, you brought on, a new contract, how do you think about clinical data in that context? I mean, how are you making that argument to the employer? Then what kind of data do you need to both bring that contract in and then continue to show, the value you're providing as you go along?
Yeah, it's a really good question. I think, in addition to the things that I talked about, which in some ways are more at that individual kind of employee level or patient level, from an employer perspective, really, I'm thinking about trying to convey to them the value of what they're paying for. So just so everybody has a frame of reference, how we have about 55% of our patients and our multi-location practice come from businesses. You could consider us a near-site player for several of those, as opposed to an on-site player, but we're talking 60 to 65 businesses. And they are paying us a monthly fee, so a retainer fee or a capitated fee, depending on what you want to call it. But in essence, a direct relationship where that primary care is carved out and attached to the medical medical plan or the health plan as part of, ideally as part of. And so we really want to make sure that we're conveying to them value. The two, I would say, low-hanging fruit as it relates to this, or for us at least, the most low-hanging fruit is making sure that their employees have a good experience. We generally think as a proxy, if we're delivering a good experience, and that those employees are satisfied, that we are in a better position to actually take better care of them, get them engaged, help them stay healthy in the first place, which is really what we look at as our primary job. And so that is certainly something that we focused on and want to relay back to the employees as best we can. The second, I think, would be basically what's the total cost of care. This one becomes more complicated from my perspective, and generally requires that the TPA or the third-party administrator that is servicing the plan on behalf of that employer is willing to kind of partner in a way that allows, most importantly, the employer, but ideally also the primary care providers to understand kind of what our overall total cost of care is as it relates to the services that we're delivering. I think beyond that, we start to think about how do we kind of triage or become aware of who are the highest risk employees for that organization and get alerted to that so that our flag is up or our radar is up to say, hey, listen, we really need to focus in on these 10 employees out of this 100 life group because we know that they are 50% of the expense for the plan on behalf of that employer. And we want to do that in a way where we're not kind of the big brother, if you will. We really want to kind of have this healthy relationship where it doesn't feel like this is being mandated by the employer, because that gets awkward for both the employer and for the employee, but really to kind of just be alerted to this idea that, hey, we really need to prioritize and try to keep these folks as healthy as possible, make sure they have open channels of communication. That one, similar to the total cost of care, also can be more challenging, especially for us as a small, so we have 65 different businesses. And let's say at this point, I think maybe 2 of them use the same TPA and a very varied number of brokers. And then you have CFOs and all the others. Like really trying to do that for all of these becomes quite tricky. But if we are able to do those things really, and those data flows come in, it kind of enables us to actually do a better job at what we're promising and saying. I certainly have seen in the on-site space through colleagues that are in that capacity where you're able to focus in on one specific employer, where that becomes a little bit less complicated. But a fair number of those on-site players really service a variety of employers, and I think similarly would face challenges when you're looking at multiple. So I don't know, Ben, if that's helpful. That's how it's a shift.
No, that's great.
And if an individual client comes in the door that we're thinking about, of course, we want to be bringing value to everybody, employee versus someone else.
Yeah, no, I think that's great. And I've always, like, the first time you told me that you were using net promoter scores, which is I've only seen software companies and looking at patient satisfaction. I think that's pretty innovative. Now, before we move on, Dr. Sarah, I want to give you a chance that you have a unique perspective, not only as a practicing physician, but also working in a large tech company that's delivering services as a in terms of what Elation does. So maybe you can just chime in a little bit from your perspective.
Yeah, it is a very different perspective because we're on the other side of this, trying to make sure that we get these independent practices or folks that are outside of a hospital or health system or other labs, pharmacies, et cetera. Like, we're trying to make that connection happen. And it can be quite challenging. Sometimes, a customer will ask us, hey, can you connect me to, Boston Heart or to, my local big hospital or health system. Often they're using Epic. They've got a big IT department, and we will reach out to them. And sometimes that takes like multiple times of us knocking on the door, trying to get them to respond to us so that we can set up a connection. Sometimes it's that they are just not sending data to the HIE. And so, you know, we say, well, everything looks like it's working on our side. So I don't know why you're not getting data. And it sort of puts the customer in the middle of all of this between like two tech vendors or two owners of data. And the data is not flowing, and the customer is sort of like powerless in that situation, because what are they supposed to do? Call Boston Heart and speak to their IT department and say, hey, why aren't you sharing data, or why aren't you responding to this request? Like, we don't want to put the clinical customer in that position. And so it really is an interesting dance that we do, trying to open these doors and get this data to flow. And then, you know, we're also acutely aware of this problem of making data timely and actionable and high quality and comprehensive. But this actionable piece is something that I'm really hoping AI is going to help us with. You know, we really want to see that a clinician doesn't have to wade through a 90-page PDF to find the 3 pieces of information that are actionable. We want AI to be able to help us surface those insights, bring the signal out of the noise, so that we're making that process so much more efficient and effective as it needs to be. Because if I'm just swimming in a pool of data and some of it's relevant and some of it's not, it's really not very useful to me.
No, that's great, Sarah. And I think we could really delve into the AI thing there, but I want to give the rest of the group here a chance to jump in. And so I'm going to channel Larry here. He asked me to kind of help with this discussion in the second half. So what we're going to do is I'm going to go down basically alphabetically through the list here. Just give each of, if you would like, no pressure, but if you'd like to just talk to your own experiences, if you have questions, comments, insights, like whatever comes to mind. So why don't we start? I think Allison, you wanna share with us from your perspective? You might be on mute there if you didn't hear me, Allison, or we can come back to you. All right, let me come back to her in a second. Uh, Juliana Perry, I guess I hope that's the right way to pronounce your name. Can you maybe from your perspective, any comments, insights, anything you want to share or ask?
Hi, yeah, thanks for the presentation. Like you all have mentioned, I have seen firsthand the disconnect between the different file types, the different, even a header, right? We could be sharing the same information. My file says patient name, your file says names, comma, patient, and that could throw off the entire upload and review process. What I've also seen is the various amount of different EMRs, EHRs, both from the ambulatory setting to the on-site clinic to the hospital setting, and how challenging it could be for those to also connect in real time to save precious time in decision making and in caring for that patient.
Oh, that's I think it's a really good perspective, and there's a couple of things I want to kind of poke out a little bit what you said, and I think that's because you bring up some really good points. Because again, you would think that sharing clinical data would be fairly straightforward, but the kind of meat we sometimes talk about it at Milliman's, kind of the meat and potatoes work that is the things that you just have to do to make data useful is really those things like different spellings of procedures or labs, or different, you not using the same units, or you, like you said, using different headers, and those things can actually prevent you from being able to use the data in any sort of scaled way, or you do any sort of analytics, or any kind of bigger insights in even individual situations. So I think that's one thing that we had to invest a lot of time in. Is you would think there'd be a fair amount of consistency, and there isn't, unfortunately. And the other piece too that you can see is that often different workflows, either from an electronic health record system or something that's custom built at, say, a hospital or a different location. You will see that those workflows actually add elements into the record that have nothing to do with the actual patient. It may be some sort of, may be very useful for that particular hospital, but it may not really, it doesn't really apply to that patient. So what happens is when the data gets shared, we're bringing all that baggage with us as the data gets shared. So I think you're really spot on there. That's unfortunately one of the things that makes this harder. And unfortunately, the clinicians and their organizations bear a lot of the burden of having to deal with this. So I saw your message there, Allison. So you back on anything you want to from your perspective? I think we've met before, and I think you had some really interesting things that you worked on there where you're from in city of Davenport. So maybe is there any comments from your side?
I would just say, to piggyback on what Juliana said, the lack of standardization across data is a huge problem, but also a willingness for partners to try to work that out, or to try to do data sharing, or even to communicate with us. And then also trying to find a platform that will pair the personal benefits information, patient data side of stuff with OC Health. Like, we're looking into that heavily. And I mean, a lack of data standardization just within each cohort is difficult enough. And then trying to look comprehensively at individuals or even at aggregate populations is just multiplied when trying to get two different categories of care to communicate together.
Yeah, that's a really good use case there, Allison, because I think I've always thought of with wearables and device data, look, a patient doesn't spend their whole life in a doctor's office, right? So or with their OT or PT or whatever. And the thing is, they live in most of their life not there. Yet most of the time, there's no insight into all the things they're doing. And most people have an Apple Watch or phone or like whatever they use, and that data doesn't actually really get leveraged because the healthcare systems aren't really set up to take advantage of that. So I absolutely agree. I think one of the things that can be really interesting here is, for example, in my case, I've been dealing with hypertension for years, and being able to show my doctor that, hey, here's how I've dealt with it over the last 15 years. And you can see these points where we try different things and we're telling a story with the data. That was actually best told when they could see my blood pressure measurements, both that I took at home, because everybody knows those are usually lower when you do it at home, and in the office, and be able to tell that bigger story. So I think that's a really interesting place where I'd like to see a lot more done there. That's great.
Yeah, we a small case study we've done with our own population was to take some of the data from the wearables and have it interpreted through it went through our fitness program for our sworn officers, our police and fire, and then have that exact same data interpreted from the personal side of things versus the occupational health side of things through different lenses. And that was alarming too. And it kind of goes to that lack of standardization, is there were different interpretations amongst the different kind of cohorts.
Yeah, no, I think that's and I encourage everybody. I saw Allison's recent presentation on some of this stuff, and I think what you guys have been doing during the city on Davenport is really fascinating. And I think I encourage everybody, if you haven't looked into what they're doing, definitely take a look, because I think they're doing some really interesting, innovative things there.
Thank you.
Yeah, one thing I see, Dr. Sayers, chat there, is that, yeah, I think one point to bring up here before we go on is, I think this is where, because I come from a kind of a enterprise data background, back when big data was still cool, and we were all those things that are now finally making their way to healthcare. And the reality is that it is a very a lot of the technologies are available and they're in place, but they're not implemented like they should have. So my chief technology officer, used to work at Apple, and I remember him telling me stories of when Apple first started trying to integrate with different healthcare providers, and they were supposed to be using this new interoperability standard called FHIR, FHIR, and it's just a new, more modern data format. All these different players in the industry said they could do it, and then Apple went to them and it's like, hey, can you handle 1 million requests in this? And their eyes about dropped out of their heads. So, and luckily we've come a long way since then, but still what you're seeing is that there's not always a lot of incentive for those changes. And I think in particularly this group, this community with where you're seeing the intersection of employers and care and different health plans, I think is a really great place to push those changes. So I'm gonna keep going down the list here. Rob Goldsmith, can you any input, ideas, questions?
Oh, just a whole bunch, and I don't quite know where to start. One thing that probably is off everyone's radar. I do some teaching in internal medicine, and the current generation of medical students and residents are being taught electronic medical records, and it's a really good thing, but there are some problems as well. Relying on the EMR encourages a cut and paste mentality, such that patients who had active medical problems in the past, those don't get deleted. Medication lists don't get updated. There are so many things that, even though they're no longer current, get carried along. Additionally, using the electronic medical record encourages a checklist mentality. Here it is. If it's not there on the electronic medical record as a question, it generally doesn't get asked or doesn't get really teased out. I found an amazing number of instances where the important information is between the checkboxes. So just as a little bit of background on how medical education is proceeding. One thing that is a little bit of a different subtopic is unburdening healthcare providers. In my group, we've done some evaluations of the amount of administrative time that is being dumped, that is living with physicians, nurses, and their administrative staffs. And I think everyone on the call is probably aware of just basic medical records, prescribing with prior authorizations and step therapies, and rejections and appeals and diagnostic imaging. This administrative burden, which is probably largely driven by the need for efficient medical care, is doing the exact opposite. My question is, what systems are in place to allow clinicians to spend more time caring for patients?
That's a great question, Robert. And I think now maybe this brings out my nerd side here, but I've always thought that those of you seem marvel is that what we really need for physicians is they need their Iron Man suit. They need something that makes them more effective and better at what they do every day rather than systems that do it for them. I think to your point, I think there's been a lot of technology that's been thrown at the healthcare industry in general that promises big things and doesn't actually deliver and actually ends up adding burdens. And so I think there's some healthy cynicism that way. But I think your point is really reducing the administrative burden rather than adding to it. And I think when Sarah brought up the AI piece, I think there's some interesting things there for sure. Unfortunately, I think some ways that AI is being used right now is it works really well for some things, it doesn't work well for others. And it can be used irresponsibly like any sort of technology. But I think exactly what you said, trying to improve that relationship of the physician and their patient and make that more effective is really key there. I mean, I don't know, Ben or Sarah, if there's any thing you want to throw in there from your perspective.
Happy to take a stab. I think it's spot on. A couple initial thoughts. So one, I think the structure of how care is paid for really matters. This is certainly biased by the type of practice that I'm in, but I think one of the attractions to the direct primary care movement and to a large percentage of the on-site, near-site movement is that we get away from a fee-for-service billing structure. So the administrative burden of having to code for a fee-for-service payment, in essence, goes away. One aspect that I will speak to that hasn't been figured out yet is that most health analytics tools still use that fee-for-service coding billing structure in order to deliver analytics. And so there are a large number of those places that I spoke to who still will create $0 claims and have that same administrative burden just in order to get the data out from an analytics perspective. So I do think that there are some forward-thinking players that are out there that are just extracting the necessary data directly from the EHR rather than relying on a claims-driven process that I think could help alleviate some of the burden that clinicians are dealing with. One, speaking to kind of AI aspect that I think has been really positive for our team of clinicians is the use of an AI scribe. So we've been really only using this for 6 months. I think there are other folks that have been using it for quite a bit longer, but the documentation burden in terms of kind of after the visit is minimized as a result of using that tool to really capture and put data in proper places so that it's more of a review and sign off rather than, hey, let's type out, dictate, and then sign off type of an approach. And we're seeing clear savings in terms of the burden there. And then the final, which I think is spoken to all the time, I just really haven't seen anybody do it well yet, is, how do we leverage kind of the broader data to surface up things to allow me to be a better doctor, right? So these are reminders that XYZ may be due, or, I'm writing a prescription for this and a reminder that, hey, listen, there may be an interaction here. Those types of things that, in essence, like I can go up and I can find that information on my own, but to have a system where it actually kind of proactively is surfacing that to facilitate me delivering better care, not in a way that's kind of holding my hand or like, slapping me on the wrist, but really there as kind of like where I'm looking at it as a real tool to kind of help me make sure I'm delivering the best care possible. I've heard people really talk about this for the better part. I think, arguably it's like one of the promises of EHRs in the first place. And I just have yet to see it really, there's just so many more examples of where basically tech has added more administrative burden than actually, made me a better doctor, that I think it's still in the early phase. So those are my initial thoughts. I don't know if that's helpful.
Well, see, Ben, you just described an Iron Man suit. That's what you need. You need to pull it all in for you, right?
If you can help give me an Iron Man suit, I'll wear it.
Yeah, I agree that I think this facilitated data transfer and communication is in ways making this problem substantially worse. And I got a lot of examples, including physicians whose practices are being significantly run by MyChart, where patients expect to get medical advice by messaging their physician through resources like MyChart. Physician doesn't get reimbursed for it. And you really need to train your patients. You need to put in guardrails and boundaries. Otherwise, that sort of messaging communication can take on a life of its own. It can reduce care quality by shortcutting, and certainly it adds a lot of work.
Yeah, no, I think you're absolutely right. There's I don't know if other of you have heard this term, but when we've come across this term healthcare 3.0, and I've seen a few different definitions of it. But what I thought was fascinating about it is this is what far oversimplifying the history of medicine, but really this idea that early on, particularly maybe couple hundred years ago, it was all about the family physician that would ride around on his or her horse and treating the local community, and there was a long-term relationship where they would deliver people's babies and have this relationship with them a long time. And then we get to industrialized medicine where we have all these amazing technology advances, but then we lose the personal touch. We lose that that individual connection, and we're just all cogs in the machine. And it seems like that vision that we're talking about here is how can we use technology to enhance and facilitate the personal connection that everybody wants. I mean, really, at the end of the day, that's what we all want. But we have to. The technology has to facilitate that, and I think that's part of the key. Is like the technology should be enhancing that relationship, not just enforcing new, different, administrative burden like we've been saying. And I think that's where AI can, in particular, can help out a lot. It can also hinder, but I think that's where, for example, the scribing, where it allows, and you correct me if I say this wrong, Ben, but I think by doing the AI scribing, it allows you as a doctor to focus more on talking to the patient rather than having the computer over there and trying to type everything where you're focusing on the patient. And I think that's a really good example, or using these AI models to pull things from the internet and pull this research for you, as opposed to just throwing AI models at medical records and then you have no idea how they came up with what they did. We still have to have traceability. I mean, we have to know where data came from, and you need to be able to understand the origins of it. But on the other hand, and that's where it can be used, badly. But I think there's some really cases where I think there's a lot of promise here. Now, I want to make sure in the last couple of minutes here, the last person here, I think I haven't got to, Kirk Manley. Is there any ideas, questions, input, from your situation?
Hi, everyone. I don't know if you can hear me all right, but
Yeah, I can hear
I'm
you.
actually, new to the organization, and so I'm just, kind of a fly on the wall, learning from all you folks and understanding some of the challenges in the work site population in terms of healthcare. So, just happy to be here, and I've only been with Triple HC since September, so still getting my feet wet in this space too. So thanks for having me.
And Kirk, you didn't get a chance to introduce yourself at the beginning. So what's AAA-HC? Is that a healthcare organization, or?
Yes. It's the Accreditation Association for Ambulatory Healthcare. And so, yeah, we accredit more than 6,800 organizations in terms of, whether it's compliance. We have different programs in the ambulatory market, also Medicare deemed status, but we also have other clients in the space of worksite health. So I'm on the marketing team for Triple HC. So just learning about your market and challenges, and it's definitely helpful for me. So thank you.
Thanks for joining, Kirk. Good to have you here. Now, I think we maybe lost a couple people as we're going along, which is fine. But the great part about joining the call is you get to talk about the stuff that's important to you. So I appreciate all of you doing that. Now, I think with the last couple of minutes here, just to kind of tie a bow on this, I want to thank Ben and Sarah for joining. I think you guys only got to see a tiny slice of the kind of experience and interesting things they bring to the table. And hopefully you'll be able to work with them and see them in person, maybe at some of the events coming up for NAWHC. But I think as we go along, I want to kind of summarize this and tie the bow on this. I mean, we're really talking about is that if what we're really trying to do here is help physicians in these clinics do what they actually want to do, which is treat patients and make their lives better health outcomes, and do it preferably at a lower cost. Data and the things that we need to get that data and use that data should be helping that, not hindering that. And I think, unfortunately, right now, the data often is a hindrance. It adds an administrative burden. It adds a lot of slowdown, and I think that's part of the key. And that's one of the things that we at Milliman are really focused on, is making that data more useful. And at the end of the day, technology is here to improve what you do every day, not to make it more difficult. So I think changing the way we think about data is, describing to patients and making it actionable and useful for the people who actually need it. And that means that different people may need different types of data. The analyst looking at population health doesn't need the same thing as a doctor, but I do think we can satisfy all those audiences. And so we see that there's huge burden, unfortunately, still after all this time that's put on physicians. And I think there's a lot that can be done on that. And I think when you too, Ben, you said a lot of good things about working with employers. And I think part of the key there is also just because the data is readily available does not mean that it's the right data. And particularly as healthcare is changing, claims data is not always the best data to understand patients. And when you in a kind of situation like we see with a lot of on-site, worksite, and direct primary care scenarios, they don't have that data. And so that's definitely something that we are focused on at Milliman, is really you would be able to use the data that's coming out of electronic health records, that's coming out of those encounters, and use that in a way that claims might have been used in the past, and get a broader picture when that makes sense. And finally, I think with the AI piece, I think we could have a whole session on that. We probably should. But there's a lot of promise with AI, and I think there's going to be a lot of good. But as with any technology, we always want to use it in a way that is actually improving the what we're trying to do. But I'm like, thank you everybody for joining. On behalf of Larry and his team, I want to thank you for joining this call. For those of you who watch it later, thank you for watching, and make sure to join some of these upcoming Monday sessions, and look forward to meeting more of you in person. Thank you for your time.